So MRI in ICU, I try to find guidelines.
Closer to the microphone, maybe?
Yeah, I try to find guidelines and didn't find it. Maybe the purpose of this our meeting is to give guidelines when to do an MRI and what are the risks exactly for doing an MRI. There are very few data and most of the time in children. So we tried in our center to define the indication for doing an MRI in our medical ICU patient. And I think we do an MRI when there is a focal signs. So this means that we need to examine the patient daily and do a neurological examination in all ICU patients, sedated or not sedated. And if there is any focal neurological sign, we do an MRI. If there are any myoclonus, we do an EEG, and if we have no explanation, we do a brain imaging, an MRI. We do, of course, an MRI if there is a coma, and we have no clear explanation for this coma, or if there is, especially in sedated patient, an alteration of a brainstem reflex that we do not understand, and if a patient is become delirious or agitated and there is no clear explanation as biochemistry, abnormality disturbances or drugs withdrawal or drugs adverse effects. We do an EEG and then we do an MRI. So in sedated patient is the quite same thing. If we have no explanation for an agitation after withdrawal of sedation, or if the patient remains comatose after withdrawal, discontinuation of sedation, or if the patient is is delirious, or if there is any alteration of a brainstem reflex or of a motor response, we do an MRI. So I will focus on three types of patient: patient with sepsis, patient with hepatic liver failure, and patient with meningitis. So sepsis, you know, is an independent risk factor for agitation, is a major cause of delirium, and is on this so-called sepsis-associated encephalopathy is occurring in about 30 to 60% of septic patients. And there is a clear correlation between the severity of this encephalopathy, measured here by the Glasgow Coma Scale, and the mortality. And what is the pathophysiology? We think that there are two main processes, the neuroinflammatory processes, and I have addressed this issue yesterday, that could be related to an alteration of the blood-brain barrier and an alteration of microcirculation, and a second process, which is the ischemic one. And we have just finished a study, and we have submitted the paper, about a prospective study, observational prospective study, and we have done an MRI in patients who were septic and septic shock and who developed an acute brain dysfunction characterized either by confusion or coma or focal neurological sign or seizure. And at the end, about 60 patients were enrolled in this study. What we found, so the main indication for the MRI was, as you can see, coma and delirium. And what we found as neurological abnormalities were leukoencephalopathy or white matter hyperintense lesions and ischemia. So, as you can see on this, we have reported these lesions in intensive care medicine in 2007. These are the white matter lesions that we can see in septic patients. This is a patient with a normal MRI. At the onset of septic shock, this patient had a cellulitis of a limb. We did an MRI, no white matter lesion. And after 15 days later, he was completely confused, and we did an MRI, and we see the occurrence or appearance of these white matter lesions that were related, in fact, to a vasogenic edema. And this white matter lesion can be more confluent and sometimes very diffuse. And in this case, it was the case of a patient, 67 years old woman with a septic shock who developed suddenly a coma. We did an MRI, and we found this acute vasogenic edema involving the whole white matter, and the patient died. I showed this picture yesterday, so I go through it very quickly, but we think that these lesions are related to an alteration of the brain barrier, and which is one feature of this so-called neuroinflammatory process, which is characterized by an endothelial activation and a dysfunction also of the microcirculation. And maybe this white matter lesion can account for the cognitive decline. And in a very recent report, Eli showed that there is a relationship in a very small cohort of patients, that these patients were at higher risk to have long-term cognitive dysfunction. Sepsis can be also associated with another syndrome, which is called the posterior reversible encephalopathy syndrome, which is also characterized by lesion of the occipital lobes and which is related to also an alteration of the BBB. So what about the ischemic process? So we found that 30% of our patients had developed an ischemic stroke, had stroke in fact, and sometimes multiple strokes, sometimes related to occlusion of the cerebral artery, here a middle cerebral artery. And it was most often revealed by a focal neurological sign. And you know that you can evoke, for instance, a stroke by doing a simple neurological assessment, such as evaluating the the tendon reflex. And here, this patient had an abnormal left patellar reflex. We did an MRI. He had a very severe RDS, and what we found, a stroke, an ischemic stroke. In here, in this patient developed suddenly an hemiplegia associated with a contralateral facial palsy and the Klobuchar-Horner signs. You know now these signs, and it was related to, as you say, as you know, because this is a very well-known syndrome, it was related to an ischemic stroke of the medulla, the so-called Wallenberg syndrome. So maybe we can also, with the MRI, evidence a microcirculatory failure. This patient was referred to our ICU for a very severe septic shock, and suddenly she developed seizure, generalized seizure. We took her to the MRI, and what we found is a diffuse ischemic damage. But interestingly, this patient was not hypertensive, and there was no desaturation. And maybe this diffuse ischemic damage was related to a diffuse microcirculatory failure. And this has been well evidenced by Fabio in a publication in Critical Care in 2010. So, and we know that the neuropathology can show, diffuse ischemic damage in patients who had died from septic shock and sometimes hemorrhage or lesion of a intravascular disseminated coagulopathy, and more exceptionally the micro abscesses. So, and it is interesting because recently, and they are very fresh slides given by Robert Stevens, who did a retrospective study in about 136 patients, and what he found, white matter lesion in about 70% of his patients, and ischemic stroke in 40% of a patient. And what is interesting in our study, that there is a clear relationship between the type of the lesions and the mortality. When the MRI was normal, only 20% of mortality. When it shows white matter lesions, 40% of mortality, and when it shows stroke, up to 70% of mortality. So what are the other causes of delirium? So we do not know if we have to do, what are the relationship of the correlates, neuroradiological correlates of delirium. There were studies using SPECT cerebral flow, and maybe it seems that there are sometimes diffuse or non-diffuse alteration of a cerebral flow in various regions of the brain, and especially the brain, the frontal lobe, or the basal ganglia. And what about the liver encephalopathy? We know that, that it's that liver failure can be associated with an alteration of consciousness, which is a very predictive factors of bad outcome, and it can be associated with various different type of cerebral neuroradiological MRI abnormalities, such as bilateral symmetric high T1 hypersignal or diffuse white matter lesions, as you can see in these slides, and T2 or flare sequences. MRI can be useful for making the diagnosis of this particular encephalopathy, the Gaillard encephalopathy, which is related to thiamine B1 deficiency, and you can see it is characterized by this periventricular hypersignal. And of course, MRI can and sometimes have to be done in patients with bacterial meningitis, and you know it can show this non-specific subarachnoid hypersignal or the meningeal enhancement. It can be, of course, it's interesting if you're to making the diagnosis of hydrocephaly or ventriculitis, and it's even better than scanner, and or for making the diagnosis of vascularitis, which is sometimes a complication of bacterial meningitis, especially when related to pneumococcal, and of the diagnosis of thrombophlebitis. And, of course, MRI is very good also for making the diagnosis of abscesses, and which is characterized by a T1 hypersignal and a T2 hypersignal. And, you know, it can help, you can make the diagnosis with using diffusion MRI. You can improve the diagnosis of microabscesses by showing this vasogenic edema around the abscesses. Or making another complication of bacterial meningitis, which is SUB-DURAL EMPYEMA. And then, of course, you know that MRI is very, very useful and has to be done when you evoke the diagnosis of herpes meningo-encephalitis, because the CT scan is often negative at the onset. And the MRI can show this typical lesion of the temporal lobes or sometimes of the frontal lobes. And, of course, it is very important if you suspect the diagnosis of vascularitis and or cerebral meningitis to do an MRI, and you will see this sometimes small size cerebral infarct or sometimes very severe and large stroke. And sometimes these particular abnormalities of the cerebral artery, which are very typical. And this is a very important diagnosis. Sometimes you have patients who are referred to you for an alteration of consciousness and with and without focal neurological signs. And you can see this type of lesions involving the white matters, and this is an acute demyelinating encephalomyelitis. And MRI is very important for making the diagnosis. So I will finish my talk by saying that MRI has to be done when you, in septic patient, when you have an acute brain dysfunction, especially if you have a focal neurological signs or if a patient remains comatose and if you have no indication. But I think that we have to work more and have a larger cohort to better assess or determine the sensitivity and the specificity, because, as you know, it's sometimes difficult to bring a patient to take a patient to the MRI, and MRI is very useful for you know, making the diagnosis of various brain diseases that sometimes are referred to ICU. Thank you very much.